Good afternoon and welcome to Propelling New York Forward, a series of conversations about the biomed industry's response to the coronavirus pandemic and how we begin to restart the economy. I'm Wynn Thurlow, Executive Director of MedTech, New York's association dedicated to growing the life sciences ecosphere. We connect the biomed industry through business development, education, and advocacy. And for those of you who'd like to learn more about MedTech and how you can connect with our members, please check us out at medtech.org. We see these conversations as integral to what we do here at MedTech, and we're able to make this series free to you thanks to the generosity of our sponsors, Regeneron Pharmaceuticals, MDR Associates, Thermo Fisher Scientific, GKG, Barclay Damon, and Fuse Hub. We'd love to have your company or organization join us as a sponsor so that we can continue to deliver high quality education to our diverse audience. I'm pleased to welcome to today's conversation, Dr. Robert Corona. Dr. Corona is the CEO of University Hospital in Syracuse. University Hospital is a level 1 trauma center and part of SUNY Upstate Medical University, the State University of New York's academic medical center. Dr. Corona has been in the thick of the battle, as it were, in terms of the coronavirus and the health care system's response to it. We're going to spend some time talking about that experience, getting a sense from Dr. Corona about where we are in terms of healthcare here in New York and what institutions like Upstate and others are doing, both in terms of lessons learned and how do we pivot again back to being a full service healthcare provider across the state. So Bob, thank you for joining us and welcome to Propelling New York Forward.
Thanks, Wynn. I'm very appreciative of the invitation and hope my presentation and our conversation provides some value.
Fantastic. Well, I'm sure it will. For those of you who are watching us, we're going to start with just a few slides and then open the screen up so that you get to see Bob and me. I'm not so sure you'll be prepared for me, but at least you'll get to see Bob. And we're going to talk for the first few minutes about today's topic. I want to encourage those of you who are joining us today to send us your questions through the Q&A box that you can find if you hover your cursor over the bottom of your screen to the right hand side. You'll see Q&A. We'll be soliciting your questions, and after we've had a chance to talk, we'll take some of those questions as well. So with that said, Bob, let me turn it over to you, and again, thanks for being here.
Thanks, Wynn. I really appreciate it. So you see, I promise you this will be a quick PowerPoint just to kind of whet your appetite, but you can see on the right side, I have the word resilient. And to many, if you look up the definition of resilient, it means that you come back from some kind of an insult or a crisis and you're back to where you were. I like to think of resilience as that you come back better. It's almost like conditioning a skeletal muscle. You work it and work it and work it, and it comes back stronger and more resilient, more endurance. And so as a teaching hospital, we have an obligation to come back as a smarter hospital. So we were strong, and you've seen our baseball caps and our masks that say Upstate Strong. We wanted to stay strong through the pandemic, and now we want to get stronger and be more resilient. So I have challenged our institution to reimagine itself as a smarter hospital. And we have pillars that we have that are strategic to our future. I'll go to the next slide. So we started out with an incident command. It ran for about 8 weeks, and it was led by our chief of infectious disease, who has a tremendous amount of experience in developing vaccines, worked with the Army, was in the Army, developed the Ebola vaccine, or worked on that, and did a number of different things. He, in addition to our incident command, which met every day, 7 days a week, twice a day, we were negotiating with all kinds of offshore organizations to try to get PPE. It was really a chaotic time in late March and early April. And we had a lot of different directives that came from the New York State Department of Health. So I think it was probably a lot easier to shut down than it is to reopen. And so there was a pretty tough directive issued for hospitals that we had to cut our elective outpatient surgeries and procedures, and we had to maintain a capacity of 70% or 30% capacity of our staffed beds. So we were staffing at 100%, but only could fill to 70. It wasn't a problem early on because we were not doing elective surgeries, we were just doing emergencies. And then it started to come to the point where all of these requirements to resume that you see underneath on this slide started to pull away. And little by little, we started to open up a little bit. And then in the middle of this month, June, we were no longer held to these criteria to qualify to keep open. We're now using regional scorecards. You can see them on the next slide. So these are now this is the new scoreboard that we have to look at. And we look at things like our testing and tracing. We have to maintain 30 per 1,000 diagnostic tests and then be able to contact trace. We have to look at the rolling average of infections. And I think New York State had its lowest rate yesterday since the pandemic started. The severity of infection measured by the new hospitalizations per 100,000. And then we're still looking at the hospital capacity. But as you can see, for instance, the day New York City opened, they did not even achieve that hospital capacity number of 30%. They were at 29%. So now the hospital capacity is looked at region by region. And the Central New York region is in good shape, as is most of the state at this point. Next slide. So, are we going to bend or break in this resilience, new thinking for the future? So we're challenging our people, and we've created these teams to really rethink things and reimagine things. So, does it make sense anymore to do just-in-time inventory? Because you can see we all scrambled to get protective equipment, and the just-in-time inventory system did not work well for us. So now we're starting to stockpile PPE in the event that we get another surge. We're digging deeper in our succession planning to expand our bench because our people were getting burnt out. I mean, if you have an incident command twice a day, 7 days a week, it really weighs on you. So we dug deeper into our personnel, and we found a lot of talent that was previously undiscovered, which has been a really positive side of this pandemic. We are looking to kind of reconstruct the future. That means you got to let go of some of the old ways of doing things. And we're reimagining what the future of our institution will look like. You might laugh if you worked in a state institution that can somewhat be bureaucratic. We're trying to address the inequality in our institution and look for opportunities for rapid growth. Next slide, please. So, what is going to be forward? Where we may have a contact-free or reduced contact economy. Our telemedicine program, I think, saved our clinical enterprise. We exploded in telemedicine consults. We also used telemedicine a lot inside the hospital because we wanted to reduce the use of PPE originally. So we started putting iPads in the room, and when patients would need attention, it may be that they just have a question and they could handle it with an iPad. So we didn't have to have so many people entering the room. We're using a lot of automation, trying to use artificial intelligence and predictive modeling. As you can see, we're using Zoom today. We've really learned how to use Zoom, WebEx, Microsoft Teams, and even FaceTime. That's helped us with some maintenance of connection. And then the innovation side, which is really exciting to me, we've developed a convalescent antibody program, plasma program. We are participating in 2 vaccine trials right now. And we're looking at various drug development. So our global health and translational science team is doing a lot of work in the biotech area. The company that spun out of our biotech accelerator, Quadrant Biosciences, that had the saliva test for autism, has developed a saliva test for diagnostic COVID virus, and it looks pretty promising. So we've had a number of institutions asking us about use of that test. We're also working with several commercial vendors to provide testing, Roche, Abbott, and BioFire. So those are exciting innovations that have come from this pandemic. The next slide, please. It's also been interesting to work with industry. We've collaborated with a couple of medical device manufacturers who want to know where the money is coming from into the hospital and how can they target their product portfolio to address where the money is. So that's been a nice relationship we've had with various industries in the area. And then it's also been interesting to see how much the government has gotten involved in the operations of the hospital, telling us what we can and can't do, dictating our visitation policy, telling us, what kind of capacity we have to maintain. That's been a little bit different. We were always used to regulatory bodies being involved in the hospital, but the government has gotten quite involved in our hospital operations. Public health has become very important now. Our public health team, which was kind of behind the curtain, is now all of a sudden in the forefront. But they've been wonderful in helping us with predictive modeling, and it allowed us to be strategic in what we did. So we're hoping to come out as a smarter hospital that's faster and things are simpler and hopefully less expensive as we develop a more resilient state. And the next slide, I think, is the last one. So I love this quote: if you don't like change, you're not going to like irrelevance even less. So we want to continue to remain relevant and be a leader in the area as a smart teaching hospital. So I thank you for your patience on another PowerPoint.
So Bob, thank you. That was a great kind of backdrop for the conversation, and I'm wondering if you can to follow up on some of the points that you made. Let's start a little bit with product portfolio and your work with some device manufacturers and others. Certainly, one of the questions that many of our members are grappling with is, where should they be devoting their resources and their spends when we are in such a period of uncertainty with respect to capital budgets and the like. And I suppose further complicated by the fact that we may have as many as 50 different reopening plans across the landscape. Do you have some sense of where you think hospital purchasing and product development is going to go over the next 12 to 18 months?
My opinion is it's definitely going to be decentralized. So the clinical enterprise is not focused so much on the inpatient world anymore. It's all about getting access to the patient to make it convenient. They've got a taste of what it's like to have easy access through telehealth and remote monitoring. So I think that that's the direction things are going, and that's where we're looking to purchase equipment to kind of expand our footprint. I'll give you an example. So at the Javits Center, Upstate was asked to provide staff, and we provided nurses, but we also provided the medical director of the Javits Center and one of the nursing officers. And they had some experience with Welsh Allen Hillrom's new monitor down at the Javits Center. So fast forward about a month after the Javits Center closed, Welsh Allen contacted me and said, hey, we've modified the monitor to, I think they put a different kind of telecommunications technology into it so that it could be used at home. And so we reconnected with some of our nursing staff and have now been working with Welsh Allen about how they're going to position that in the market. The other thing is Welsh Allen again reached out to us about talking to our finance people about where the money comes from and where it's going. And so we connected our CFO with some leaders at Welsh Allen, and they had a really good, productive meeting on where we're getting our money from the government and where we intend to spend it in the future.
So let's talk a little bit more. In fact, let's dive a little into the whole money piece. It occurs to me that there may be actually a couple of seemingly contradictory moves going on at the same time. On the one hand, there certainly had been a trend toward obviously shortening hospital stays, which increased pressure on hospital bottom lines. Some real question about how were hospitals going to really handle the legacy costs of large physical capacity. I'm curious to know if you think that trend will be reversed now that we've had a taste of what could potentially happen if we don't have physical beds for folks to move into. And at the same time, where do you see the reimbursement models going with respect to telemedicine, telehealth, and other remote modalities? Is that going to increase downward pressure on your budgets? And if so, kind of what's the plan?
Well, let me tackle the first question. The capacity is an interesting thing, right? So does it make sense to have 100% staffed beds and only be able to use 70%? That's not sustainable. So when the governor asked us early on, I don't know if you remember when the panic about the ventilators came about and whether we would have enough beds, he asked all the hospitals to come up with a plan to surge up 50%. We were able to come up with a plan to surge up 75%. So I think the model, and this is not anything new, I mean, people have been looking at surge capacity for a while. The model is to have the flexibility in your beds, and we've gotten some relief on having flexible bed designation. I think that's the model, to be able to flex up when you have a surge and flex back down when you don't, because you can't sustain, especially we have such a high labor cost with our fringe benefit rate. Staffing at 100% and only be 70% capacity is really tough. So I think we're looking at all different kinds of models. Our emergency room was often crowded with 40 to 50 people waiting for a bed on every given day, and we would be on diversion. This really relieved that, the pandemic, and now we're trying to figure out ways to triage patients before they come to the ED. I mean, many are still afraid to come to the hospital, so that's keeping the numbers down, but it's going to ramp back up again, and we have to figure out ways to triage patients before they get to our EDs so that they don't get overcrowded. On the reimbursement side, right now there's parity on the reimbursement with a telemedical visit and a office visit. New York State, as far as Medicaid, is in parity. We're worried a little bit about what CMS is going to do with Medicare and what the private payers will do. The other thing is on testing. Who's going to pay for the testing? So the nursing homes have to test their staff. They did have to test them twice a week. That was substantial. Now it's once a week, but all these college students now, the colleges are asking Upstate if they will be able to help them test. And SUNY has 450,000 students coming back, some of them from areas that had a high number of viral infections, going into a small town upstate New York with a small hospital that might not be able to manage an outbreak. So, are they going to test all of their students? Are they going to be more focused and ask them to fill out forms that indicate whether or not that they may be high risk, and then only test those students? There's still a lot of stuff going on regarding testing, and the insurers, the privates, have told many of the colleges they will not pay for student testing because they don't feel it's medically necessary.
So I guess that really does kind of sharpen the question. If the insurers are not going to pay, certainly in our private insurance model, do you see that as a cost that's going to be shifted to the consumer, to the patient, or is this going to be a cost that our employers and educational institutions are going to have to bear?
Well, I don't see how the educational institutions are going to be able to pay because they're already, looking at decreased number of students and some difficulties related to, managing the pandemic, managing the infections. The businesses may be hit. I don't really know. I know we're getting a lot of mandates that come out of Albany, but no way to pay for them. So I don't know. It remains to be seen. It makes me nervous.
And let's get back for a minute to the patient experience in terms of telemedicine, telehealth. I got to imagine that for many patients, the COVID experience has been their first introduction to remote diagnostics, remote analysis, remote being seen by doctors. What's your sense from your patient population about the willingness of patients to participate in telemedicine and how that experience has changed for them?
So you really have to segment it into age groups, right? So the younger people, this is just the way they do things, right? And it's been very easy for them. Some of the older individuals at first found it a little bit awkward, but once they got comfortable with it, they really liked it. And especially you think about how difficult in the wintertime it is to kind of get out of the house and find a parking spot and wait in a waiting room. They ended up really liking it, and now many of the patients want to do telemedical visits. Essentially, when you think about it, telemedicine's been around a long time, and it really took the pandemic to kind of accelerate it to be adopted the way it is now. And I think a lot of people don't want to go back. We teach medical students, look, you can make the diagnosis, people quote the number of 80% of the time just on the history. So if you're sitting and talking to somebody and you have the extension of your eyes and ears through a video conference, and then some of the attached devices now that you can get oxygenation and blood pressure, and even if you have a healthcare provider on the other end, you can auscultate for heart and breath sounds. You can do a lot of the exam. Our stroke service, I think, now has 13 different sites across the state where they make the evaluation of whether or not somebody's having a stroke via the telestroke. We've been doing telepsychiatry, I think, for approximately a decade. We've been doing telepathology for 2 decades. So I think it's here to stay. It certainly makes a lot of sense.
So help me understand, Bob, if you can. I guess I can imagine in pathology and certainly in psychiatry, effectively non-touch diagnosis. Help me understand where you think we're going to be going in terms of either emergency care or when you talk about stroke. Operationalize that for me. What happens? Somebody, I call an ambulance, EMTs come. I mean, how am I being assessed for my stroke symptoms?
Yeah, usually you have a healthcare professional on the other end, communicating with one at the referral center, and you go through the typical analysis of numbness and weakness and dizziness, headache, all that kind of stuff, and they make the evaluation whether or not there needs to be a thrombolytic given, whether the patient needs to be transferred right away, how rapid, those kind of things, and you can apply that to a number of different disease states as you're triaging people, whether or not they need to come to an emergency room. A lot of the people that come to the emergency room do not need to come to the emergency room, but it's the quickest and easiest way sometimes to default to go to the emergency room when you want a rapid assessment. But if you could get that assessment over a video teleconference, I think people would prefer that. you certainly don't want to come to the hospital if you don't have to.
And I'm going to ask you to put on or gaze into your crystal ball. You know, as we've looked in New York at our falling rates of infection, certainly the falling death rates, we seem to be pretty confident that we are on the downside of the surge here in New York. What's your sense as we relax social distancing requirements, as we begin to reopen, and as you look across the country in places that have been less restrictive in their practices? Do you see a second wave coming here to New York State? And if so, can you give us a sense of when you think that might be? And what are you doing at University Hospital to prepare for that potential?
So, you know, we work every day with our public health predictive modeling team, and they give us the infection rates, the R values. And, we were worried about a potential uptick after Memorial Day holiday. It didn't happen. I think for the most part, most people are being respectful of one another and wearing a mask and washing their hands and keeping socially distanced. We're now worried about where we had these rallies in town with a lot of people that were not socially distanced and did not mask, whether or not we would see an uptick. So far, we have not. The trend continues to go down for our region and most of the state. So the interesting thing people are talking about is why are the states largely that are states that are, sunny and warm, why are they getting these high infection rates? And some people are theorizing that now those people are going indoors, and because they want the air conditioning where we were indoors for the heat. And, the spread is probably most commonly by people indoors with, close proximity. I've seen all kinds of numbers about if you're in the same room with somebody, how long you have to be in that room and close to them to get enough of an inoculum of virus to get sick, and it's 10 minutes, 15 minutes of close contact is considered an exposure. That could potentially be the reason why we're seeing upticks in some of these other states, along with the fact that they're not being respectful of one another and they're not masking. When you're in a close quarters, the masking is not so much to protect yourself, but if two people have the mask on, you're protecting each other. I talked to the employees of the hospital about the Spartans when you used to if you were a Spartan and you dropped your helmet or your chest shield, you were disciplined. But if you dropped your armored shield that protects the group, that was considered the worst thing you could possibly do because you weren't protecting the group. So if you don't wear a mask, you're really not showing respect for the other people in your working environment. So I'm hoping that we continue to do what we did. I mean, it's pretty remarkable what New York State did. We were the worst, probably place in the world, not upstate, but downstate, and really turned the corner. And I don't know how many, it was 60-something days.
So one of the potential downsides in some ways of having been successful is obviously we have not developed herd immunity because we've kept people relatively shielded from the disease. Do you worry at all about the period between now and whenever we develop a vaccine of rampant outbreaks?
I mean, I worry about it, but I can't focus on that. I'm trying to focus on what we're going to do to reduce certainly the mortality, but also the morbidity. It was very exciting to hear about the dexamethasone help yesterday. We've been working with anti-inflammatories and some of the antivirals. We've been very encouraged about the convalescent plasma and how that's worked. And, I'm seeing very optimistic timelines related to some of the vaccines that are coming out. I mean, Upstate's already got 2 trials going on for a couple of the vaccines. So, I'm I'm optimistic. Now, am I worried? Yes. We're ramping up in stockpiling PPE. We're looking at new ways to manage patients, and we're ready again with an incident command team in the event that we start to see things turn. I don't think they'll ever shut the economy down the way we did. So we've got to be focused on disease suppression. We have to find the hotspots and isolate them and do contact tracing and be more precise in the way we approach things.
And Bob, one of my observations has been, certainly there have been vivid examples of hotspots that have developed in places of high concentration, super spreader events, meat packing, food processing plants, and other things, certainly in nursing homes. By and large, my sense is, and you can correct me if I'm wrong, that dynamic has not happened at our hospitals. Is that due to increased or more stringent protocols that hospitals had in place, or is it for some other reason? And what can the rest of us learn from the experience that hospitals have had?
I think you nailed it. I think it's our protocols have been very strict. We have a very strict visitation protocol. We've been using a lot of technology to reduce the number of face-to-face encounters. We've been very disciplined with our use of PPE. We're fastidious about hand washing. In fact, we just implemented a system that monitors the hand washing that individual healthcare providers do within the hospital. A technology called Swipe Sense. And we constantly communicate with all of our staff about the proper etiquette, wearing the mask. We ask people to wear a mask into the institution. Everybody that comes in gets a fresh mask, a surgical loop mask. We reserve the N95s for the people that are doing high risk procedures. We use face shields, the PAPRs, the things with the oxygen systems on them. So we've been pretty fortunate. We have a very low incidence of infection. Before
I hit you with the next couple of questions, I just want to remind our audience that if you've got some questions for Dr. Corona, please feel free to send them to us in the Q&A or chat boxes across the bottom. Bob, one question that did come in, and you're going to have to excuse me, as you know, I don't have a medical background, but we did get a question from one of our participants who was asking about the saliva test that you talked about that Quadrant Biosciences has developed. And the question is that I hope I'm pronouncing this correctly, is that a Nicoya, Nicoya, by any chance?
I'm not sure what that is, to be honest with you.
All right, maybe our guest will.
Is that a brand? Because this is a laboratory developed test that was done by Frank Middleton in the laboratory, and he's applied for a emergency use authorization through the FDA.
And is this an active disease test or an antibody test?
Active disease. So it's a diagnostic. It's a PCR based test. The nice thing about saliva, it seems to be a little bit more stable than the nasopharyngeal swab, and certainly a lot less painful.
And let's talk as well about, I've got a question. Actually, I'm going to stop saying what I was going to say and read the question that we have. I'm hoping you can talk to us a little bit, Bob, about where you think, at least at Upstate and perhaps maybe across the world of academic medical centers, do you think your research emphasis has been modified or will change as a result of your experience with COVID-19?
Absolutely. Absolutely. For instance, our public health department was kind of out in doing its own thing, and I don't think really had the attention it deserved. But boy, it really stepped up in this pandemic and was a wonderful resource for Upstate and I think the community at large. Some of their predictive modeling and evaluations were outstanding. We shared them with the governor's team. We shared them with the business community. And I think public health now hopefully gets greater attention because you can see how important it is, especially in situations like this. I don't think this is going to be the last big infection problem we have to deal with. Hopefully we never get another pandemic for X number of years, but we're definitely shifting our resources into infectious disease, infection control, and public health. Our global health and translational science team have gotten a bunch of new grants, and as I mentioned a couple of times, they're doing vaccine development, convalescent plasma therapy, and a lot of research in that area.
And certainly in the midst of this pandemic, there has been a relaxation almost really across the board in the regulatory sphere. Certainly from the FDA in drug approval and protocols. I presume that was also true in the other regulatory realms that you deal with. Do you have some sense, you talked earlier about kind of slashing through bureaucracy, and my sense is that you were probably referring more to the state bureaucracy with respect to the nimbleness of the institution. But where do you see the regulatory environment going as a result of all of this?
So, the state regulatory environment, it got quite complex. What we could do, what we couldn't do, what were the numbers? If you shut down your elective surgery because of capacity, you could apply for an exemption with the State Department of Health, and whether they were going to grant it or not, whether it was based on an individual hospital or a region. It got confusing, and a lot of these directives came out, I think, out of the governor's office, and then we relied on the Department of Health to translate them for us. And so it was tough sometimes. I think on the device and drug regulations, those loosened up quite a bit, and we've had some negative fallout from that. I mean, you've seen some of the antibody tests, for instance, have been woefully inaccurate. And so now there's not a lot of trust for a lot of the antibody tests, but some of them are really pretty good. And, this whole concept of neutralizing antibodies, which are the antibodies that really protect you from the virus, and how long do they protect you? Those are big questions, but we're starting to get some answers. There's a finger stick blood antibody test that's close to being approved in an emergency use. Also, there's a test called a Pixel, which is almost like a home pregnancy test where you swab your nares. You don't have to go all the way up deep into your nasopharynx. You send the test in, and they say within 24 hours they'll tell you whether you have COVID or not. So I think a lot of those kind of tests will be helpful. We use a test also called BioFire that they've just added COVID to a panel. I think it's somewhere around 23 different respiratory pathogens, or we call them influenza-like illness. So the nice thing about that is if you're COVID negative, chances are you're going to have one of the other 20 plus viruses or bacteria that are causing you to have respiratory infection. And that will help us with our determination of whether you need to be admitted or whether you can go home with therapy. So I'm pretty excited about the opening up of the regulatory world on the drug and device side.
And let me also return back to the issue you talked about earlier, which is stockpiling and kind of the negative experience that you found in just-in-time inventory systems here. I'm guessing, tell me if I've got this wrong, that your stockpiling is going to be relatively limited in scope, or are you looking at opening up your inventory writ large?
Well, so everybody's trying to stockpile now, right? So we're pretty competitive, and certainly things that used to cost, 50 cents are now $8. Um, we still have to be judicious about how we use like N95 masks because they're tough to come by. We're supposed to have a 90-day supply. Sometimes it's tough to keep a 7-day supply of certain supplies, but we've got a whole team that just does this all day long, and we're hoping that if we do get a second wave, I'm pretty confident we're going to be in a much better situation with PPE.
We got time for just about one more question. Maybe we can squeeze in two. One of our attendees wants to know, how long do you foresee the wearing of masks? Is this going to become our new normal, or do you think there's a time at which we'll be able to take our masks off in public?
I think it's probably not going to be until we have a substantial number of people vaccinated, or somehow we achieve a herd immunity through infection. It's been, it's funny, early on people were saying that the masks were not that big of a deal, and then it seemed like overnight they became extremely important. I think the key to know is the masks really protect others more than they protect you. The combination of a mask and a face shield is really a pretty effective way to protect yourself and to protect others, because the face shield will certainly protect you from getting hit. And certainly your eyes are a conduit for the virus as well. So I think it's going to be a while. Now, people don't need to be wearing masks when they're driving alone in their car, or if they're able to be distanced and they're outdoors, for instance. I think mainly you just need to wear a mask where you're not confident that you can keep some kind of physical distance, and you're going to be in a crowded place with a lot of people for an extended period of time. Probably wearing masks on airplanes is going to be status quo for a while. Movie theaters, those kind of places where you're in with a group of people and you're there for a period of time, which would expose you.
And let me ask you one last question that I think we can squeeze in. You talked about accelerating the pace at which the hospital and other places are going to be transferring to telehealth, telemedicine. What changes do you foresee in terms of in-person inpatient care? How has that experience changed, and how do you think it will be changed for hospital patients in the future?
I think we're going to use more communications and computing technology in the hospital itself. I think those people who are less acute will be managed more on an outpatient basis. So there'll be decentralization in use of telemedicine technology inside the hospital to reduce the amount of PPE we need to use and to reduce the exposure and protect both patients and staff. We can use iPads and phones to do FaceTime. And before this pandemic hit, we were working with Apple Computer about how to use iPads within the hospital. There's a number of different ways you can use it, especially in pediatrics. But a lot of times patients just have questions, or they want their curtains opened up in the room, or they want the temperature adjusted in their room. That can all be done remotely. And if you reduce the number of times a nurse has to go into the room, or if the doctor's at one side of the hospital and there's a quick question a patient has, there's no reason why you can't just do it via telecommunications. So I think we've now become really accustomed to it, and I think you're going to see a lot more use of it.
Terrific. Bob, I appreciate you spending the time. I know our audience was thrilled to hear from you. I want to remind people all of our Propelling New York Forward episodes are available to be listened to again. You can find them at our website, medtech.org. Next week, we'll be talking with Dr. Venu Govindaraju, the Vice President of Research and Economic Development at the University of Buffalo, where we'll be talking about bringing the research environment back onto line and where commercialization and research out of our university systems is going. So again, Bob, thank you on behalf of all of us at MedTech. Thank you to all of our participants, and we'll see you next week.
Thanks, Wynn. Appreciate it. Thanks for listening.